Good day, everyone. This is Amy Downing, nurse practitioner student from Purdue University Global. Today, it's Unit 8 assignment, so we're going to do the assessment from head to toe. I'm going to start with the head. So, examination of the head, inspection of the scalp and hair, the skull, the face, and the skin. So what are we going to inspect for the scalp and hair? So my volunteer is bald, of course, but if your patient has hair, note its quantity, distribution, texture, and any pattern of loss. You may also see loose flakes of dandruff. Now, if the patient has hair, part their hair in several places and look for scaliness, lumps, nevi, or moles, and other lesions. In his situation, I can easily inspect his scalp and the skull itself by observing the general size and contour of the skull. So I'm going to note for any deformity, depression, lumps, or tenderness. Now I have to recognize also irregularities in normal skulls, such as those near the suture lines between the parietal and occipital bones. With the face, note the patient's facial expression and contours. Observe for asymmetry, involuntary movements, edema, and masses. And for the skin, observe the skin on the face and head, noting its color, pigmentation, texture, thickness, hair distribution, and any lesions. So I'm going to go ahead. I'm going to touch your head, okay? It's a little bit of dryness on this part, okay? The scalp is healthy, it's smooth, all shape. The skull, the shape, the general size, I could tell it's symmetrical. And the face, and the contour, it's normal. And the skin, he has obviously fair skin, and I can see some freckles but redness on his face, but it's typical and normal to him. So this one we're going to do examination of the eyes. We're going to do the assessing the visual acuity first. To assess the acuity of central vision, use a well-lit Snellen chart if possible. Well, I have a Snellen chart that's located on the wall, and it's located 20 feet from where the patient is standing. So patient who wears glasses other than for reading should put them on. Ask the patient to cover one eye with a card to prevent looking through the fingers and to read the smallest line of print possible. Now note, coaxing to attempt the next line may improve performance. A patient who cannot read the largest letter should be positioned closer to the chart, not the intervening distance. Identify the smallest line of print where the patient can identify more than half of the letters. Okay. Now we're gonna do the reading. Can you cover one of your eyes? Okay, I'm gonna point. There you go. I'm gonna point here. These letters. Okay. Sorry. Can you read this to me?
D, E, F, you have to move your finger, please. Thank you. D, E, F, P, O, T, E, C.
Very good. How about the second line, the number 7 line?
F, E, L, O, P, Z, D.
Can you cover the other one? Can you read this to me backwards?
Which one?
This one.
Above the red line?
Yes.
O, D, no, it's kind of hard.
So, okay.
Yeah, my eye is still adjusting from being covered too.
All right, how about this above the green line?
P, Z, O, F, D, E.
Okay.
D, GGPOLEF.
All right.
OCT.
Okay.
Yeah, whatever.
Thank you. So record the visual acuity is expressed as two numbers. In his case, he is 20/30. The first indicates the distance of the patient from the chart, and the second, the distance at which a normal eye read the line of letters. Testing near vision with one held card can help identify the need for reading glasses or bifocals in patients older than 45 years old, and he is above 45 years old. You can also use this card to test visual acuity at the bedside. So held 14 inches from the patient's eyes, the card stimulates a Snellen chart. If you have no charts, screen visual acuity with any available print. If patients cannot read even the largest letters, test their ability to count your upraised fingers and distinguish light, such as your flashlight from dark. So with him, he was able to read, but his vision is 20/30. Okay, we're going to perform finger wiggle test. So I have to position myself about an arm's length away from the patient, and I'll instruct him to close one eye and have the patient cover the opposite eye while staring at my open eye. When the patient covers the left eye to test the visual field of the patient's right eye, you should cover your right eye to mimic the patient's field of view. So I'm going to place my hands about 2 feet apart out of the patient's view, roughly lateral to the patient's ear. While in that position, I will wiggle my finger and slowly bringing my fingers moving forward into the patient's center's view. And I'll ask the patient to tell me as soon as he sees my finger movement. So this is the test each clock hour, at least each quadrant. Test each eye individually and record the extent of visits in each area. Note any abnormal field cuts. So I'm going to observe that. So this is the demonstration. Can you please stand up? We're going to do first the basic side. You have to stare at me first without covering your eyes first. And let me know if you can see my...
See both. Yeah.
Okay, now cover, where's the card? Cover one of your eye, cover your left, and I'll cover my right, and I will test it in the quadrants.
I see it. I still see it. Still, yes.
Okay.
Yes.
How about the other, cover the other one?
Yes. Yes, 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 yes.
Okay, very good. Now he demonstrates that he passed the finger wiggle test. So this time we're gonna do the kinetic red target test. Facing the patient, move a 5mm red top pin inward from beyond the boundary of each quadrant along a line by setting the horizontal and vertical meridians. So I'm gonna ask the patient when the pin first appears to be red. So position and alignment of the eyes, standing in front of him, and I'm gonna survey the eyes for position and alignment. If one or both eyes seem to protrude, assess them from above. So we're gonna start on the side because it's not protruding. Okay, you gotta tell me if you see it red coming to you.
Red. 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 Red.
Okay, very good. Okay, now I'm going to inspect the eyebrows. Inspect the eyebrows, noting for their fullness, hair distribution, and any scaliness of the underlying skin. I'm going to touch your eyebrows and you can inspect it. I already washed my hands. Okay. Okay, your Eyebrows are thick, no dryness, well moistured. Alright, now I'm going to inspect the eyelids. Note the position of the lids in relation to the eyeballs. Inspect for the width of the palpebral fissures, edema of the lids, color of the lids, lesions, condition and direction of eyelashes, and advocacy of eyelid closure. Look for this especially when the eyes are unusually prominent, when there is facial paralysis, or when the patient is unconscious. So luckily, our patient don't have facial paralysis and he is very conscious. I'm just gonna inspect the eyelids. I'm still gonna extract it, okay. And I'm gonna look at the eyelashes, beautiful lashes. And those are natural lashes. Beautiful eyelashes. I'm jealous. So the findings are, a patient has normal visual fields. The iris of the eyes are symmetrical. Eyebrows are normally thick. Eyelids are in the right position in relation to the eyeballs and no lesions noted. Eyelashes are normal and the direction is appropriate away towards the side and thick eyelashes. So we're gonna check the lacrimal apparatus. Briefly inspect the regions of the lacrimal gland and lacrimal sac for swelling. Look for excessive tearing or dryness of the eyes. Assessment of dryness may require special testing by an ophthalmologist. Test for nasolacrimal duct obstruction. Now I'm gonna ask you to look up and I will press on the lower lid close to the medial canthus, just inside the rim of the bony orbit. This compresses the lacrimal sac and I have to look for fluid regurgitated out of the puncta into the eye. But I will assure you that I'm gonna avoid, if I see any inflammation, I'm not gonna touch it. But obviously I can see that you don't have inflammation, so can you look up? Alright, very good. So there's absence of dryness and excessive tearing in his eyes. Okay, this one we're going to check the conjunctiva and sclera. I'm gonna ask the patient to look up as I depress both lower lids with my thumbs, exposing the sclera and conjunctiva. I'll inspect the sclera and palpebral conjunctiva for color, and I will note the vascular pattern against the white sclera background. If you need a fuller view of the eye, rest your thumb and finger on the bones of the cheek and brow, respectively, and spread the lids. You can ask the patient to look at each side and down, and this technique gives you a good view of the sclera and bulbar conjunctiva, but not of the palpebral conjunctiva of the upper lid, for what you need to avert the lid. So here's the demonstration. Already in my hands. I'm gonna press down, look up. Alright. I'm looking at the veins. Look down. Look this. Okay. Look at the sides. Okay, very good. Conjunctiva and sclera is clear, white in color, and conjunctiva is pinkish in color and no redness noted. Alright, this time we're gonna check the cornea and lens. With oblique lightning, inspect the cornea of each eye for opacities. Note any opacities in the lens that may be visible through the pupil. So the iris, at the same time, inspect each iris. Markings should be clearly defined. With your light shining directly from temporal side, look at each crescentic shadow on the medial side of the iris, because the iris is normally fairly flat and forms relatively open angle with the cornea, and this lighting casts no shadow. So I'm going to use this pen light and I can compare that. All right. I'm going to start here. Very good. No opacity is noted in both eyes, and both iris are normally flat. This one we're going to assess the pupillary reaction to light. In dim light, which I'm going to dim now, and I dim the main light. Okay, this is dim. Oops. In dim light, test the pupillary reaction to light. Ask the patient to look into the distance and shine a bright light obliquely into each pupil in turn. Both distant gaze and oblique lighting help to prevent a near reaction. And I'm going to look for the direction reaction, which is the pupillary constriction in the same eye, and the consensual reaction, the pupillary constriction of the opposite eye. Always darken the room and use bright light before deciding that a light reaction is abnormal or absent. If the reaction to light is impaired or questionable, test the near reaction in both dim and normal light. So we're going to pretend that, and we're going to demonstrate that later. Testing one eye at a time makes it easier to concentrate pupillary responses without the distraction of extraocular movement. So we're going to do first this with the pen light. I'm going to strike it. All right. So this time I'm going to hold. My finger, or better yet, I'm going to use this one, about 10 centimeters from the patient's eye, and I'm going to ask the patient to look alternately at it and into distance directly behind it. And I'm going to watch for pupillary constriction with near effort and convergence of the eyes. The third component of the near reaction, accommodation of the lens that brings the near object into focus, which is not visible. Then I'm going to compare the normal light reaction and near reaction of benign anisocoria with the constriction abnormalities of tonic pupil and oculomotor nerve, cranial nerve number 3, paralysis and dilation abnormalities if there's any. Okay. All right. This is look at this one alternately and at it and into the distance directly behind it. All right. Okay. I noted a good pupil constriction and normal dilation on both eyes. Okay, this one we're gonna assess the extraocular muscles. Standing about 2 feet directly in front of the patient, I'm gonna shine a light into the patient's eyes and ask the patient to look at it. Inspect the light reflection in the corneas and should be visible slightly nasal to the center of the pupils. So, in addition, a cover-uncover test may reveal a slight or latent muscle imbalance not otherwise seen. This is particularly useful in examining the children. Okay, so similar to the first one, the still ocular muscle, this one I'm going to assess, I will look for normal conjugate movement of the eyes in each direction, and noting any deviation from normal or disconjugate gaze, and liglag as the eyes move from up to down. All right. Yeah. Normal extraocular muscles noted. Okay, this one we're going to test the 6 tests of extraocular movement. I'm gonna ask the patient to follow my finger as I sweep through the 6 cardinal directions of gaze. making a wide H in the air. Lead the patient's gaze to the patient's extreme right, to the right and upward, and down and on the right, then without pausing in the middle, to the extreme left, to the left and upward and down on the left. Okay. I'm going to start here. In addition, pause during upward and lateral gaze to detect nystagmus. Move the finger or pencil at a comfortable distance from the patient. Because middle-aged or older adults may have difficulty of focusing on near objects, increase this distance. Normal conjugate movement of both eyes and absence of nystagmus, absence of rim of sclera above the iris. Right. Okay, we're going to test for convergence this time. So I'm going to ask you to follow my finger as I move it in toward to the bridge of your nose. Okay. Thank you. Okay. So findings is both eyes are normal in converging test. Able to follow my finger within 5 centimeter to 8 centimeter of the nose. This is ophthalmic examination. In general healthcare, examine your patient's eyes without dilating their pupils, which can obscure important neurologic findings. Therefore, your view is limited to the posterior structures of the retina. To see more peripheral structures, to evaluate the macula well, or to investigate unexplained visual loss, consider referral to ophthalmologists for pupillary dilation with mydriatic drops. Steps for opthalmoscope examination: darken the room, turn the lens disc to the zero diopter, hold the ophthalmoscope in your right hand and use your right eye to examine the patient's eye. Hold it in your left hand and use your left eye to examine the patient's left eye. Hold the ophthalmoscope firmly braced against the medial aspect of your bony orbit with handle tilted laterally at about 20 degrees. Slant for vertical. And check to make sure you see clearly through the aperture. Examination, no opacities noted. The two red reflexes are noted symmetrical. So this time I'm going to look for papal edema, examining the optic disc, okay, of the retina. I'm going to demonstrate it now. So I'm pretending this is the ophthalmoscope, and if you need to adjust it, the adjustment is on the side. You can use your thumb if you need to adjust. I think it's more natural. And it's the same thing. Make sure the room is dim, not this kind of dim, but really dim. And again, test your ophthalmoscope in your palm before you use it. And of course, you have to tell the patient what you're going to do. So it's the same way. I'm going to lift his eyebrows. Okay. All right. And close to the eyelashes, but not touching it. All right. And then you will look for the veins, the direction of it. Okay. So far, so good. Now, if you can do both, then by using one hand, that is better. Okay. But I'm more comfortable doing this. But you can also do this. Okay. On the other side of the eye, you can use the your other hand and then lift the patient's eyebrows, his left eyebrows, and then use your left hand to hold the ophthalmoscope. Okay. Very good. So that's my most comfortable way to detect the papal edema. So he's good. He doesn't have any swelling. So the inspection of the retina is the same way, but including in retina, you have to include the arteries and veins as they extend to the periphery, arteriovenous crossings, the fovea and the maula, and distinguishing the arteries from veins. You got to note for the color, like for example, the light red or dark red. In his case, I noted light red, so it's not really a concern, and he has a smaller veins. Light reflexes, he has a good eye reflex reaction to the light. So what are my findings? No pupil edema, veins in retina is bright red, and no lesions. He really has a good retinal reflexes as demonstrated. So this time we're going to examine the ear. We're going to start checking the auricle. So I'm going to inspect the auricle and the surrounding tissue and for deformities, lumps, or skin lesion. Simply, I'm going to demonstrate it. You can ask your patient to move his head on the side and you can visibly see it. If you want to inspect the inner, you can pull the ear up and you can press this part of his ear and the bony part behind his ear. Okay. So no deformities, no lesion noted. Okay, this time we're gonna test the assess the ear canal and drum. And to see the ear canal and drum, I have to use the otoscope. Okay, with the largest ear speculum that inserts easily into the canal. Position the patient's head so that you can see comfortably through the otoscope. To straighten the ear canal, grasp the auricle firmly but gently and pull it upward, backward, and slightly away from the head. Holding the otoscope handle between your thumb and fingers, brace your hand against the patient's face. Your hand and instrument can then follow unexpected movements by the patient. Now, if you are uncomfortable switching hands for the left ear, you may reach over the ear to pull it up and back with your left hand and hold the otoscope steady with your right hand as you gently insert the speculum. Now, we're going to insert the speculum gently into his ear canal, directing it somewhat down and forward and through the hairs. If any, inspect the ear canal to note for any discharge, foreign bodies, redness of skin, or swelling. For example, cerumen. Now I'm going to inspect also the eardrum, which I'm going to note for color and contour. The cone of light, usually easy to see, helps to orient me. That's the landmark. Identify the handle of the malleus, noting its position, and inspect the short process of malleus. Gently move the speculum so that you can see as much of the drum as possible, including pars, fascia superiorly, and margins of the pars tensa. Look for any perforations. The anterior and inferior margins of the drum may be obscured by curving wall of the ear canal. So here's the demonstration. Of course, I have to light this. Okay, can you move your head a little bit on the side? And I'm gonna tilt his head a little bit. Yeah, it's painful?
Yes.
I'm sorry. Okay, and I'm going to insert the speculum slowly and gently. Okay, clear. I can see hair, fine hairs. I can see his eardrums. Beautiful. Okay, now I'm gonna check the other side. I see hair. Okay, a little bit redness. All right, very healthy eardrums. So we're going to do the hearing test. In the previous units, we already demonstrated the tuning fork test and the Rhine test. But I'm going to do the basic hearing test, which is the whispered voice test. So I'm going to occlude the opposite side of the patient's ear, and I'll position myself here, and I will whisper numbers and words, and he will repeat it, okay?
1, 2, 3, Jack and Jill. 1, 2, 3, Jack and Jill.
Okay, good. Now the other side.
1, 2, 3, Jack and Jill. 1, 2, 3, Jack and Jill.
Good. So for the tuning fork test, make sure the room is dimmed and quiet, and make sure to use 128 hertz or 500 um, 512 hertz. So same as with the Rhine test, you're gonna use a tuning fork. So findings, his hearing test is good. There's no problem noted, and he's able to repeat the numbers and words I stated. Now we're going to do the examination of the nose and paranasal sinuses. I'm gonna begin by inspecting the anterior and inferior surfaces of the nose by gently putting pressure on the tip of the nose with my thumb. Usually widens the nostrils. And I'm gonna use a pen light to obtain partial view of each nasal vestibule. Now, if the nasal tip is tender, the gentle and manipulate the nose as little as possible. So I'm going to note for any asymmetry and deformity of the nose. Patient's nose is symmetrical and there is no deformity. So this time we're going to check the nasal obstruction, which actually we did this previously in the previous unit, but I'm going to re-demonstrate it again. So I will cover one of his nostrils and I will ask him to breathe in, okay? Sniff, exhale. Exhale. Do you have any problem?
I'm stuffy.
It's stuffy right now. So this one, I'm going to inspect a couple of things. I think more than that. So I'm going to inspect the inside of the ears with an otoscope, and also inspect the nasal mucosa, the nasal septum, and any abnormalities. And inspect the nasal cavity through anterior nares. So with the otoscope, the largest available ear speculum is okay to use. It's recommended to use. So what I'm going to do is I will tilt the patient's heads back a bit and insert the speculum gently into the vestibule of each nostril, avoiding contact with the sensitive nasal septum. Hold the otoscope handle to one side to avoid the patient's chin and improve my mobility. By directing the speculum posteriorly, then upward in small steps, I will try to see the inferior and middle turbinates of the nasal septum and the narrow nasal passage between them. Okay, and then checking for the sinus tenderness as well. I will press up in front the frontal sinuses from under the bony brows, avoiding pressure on the eyes, and then press up on the maxillary sinuses. So I'm gonna do all of those in this clip. Okay. So this is my otoscope. Okay, I'm gonna check it again. And I'm gonna tilt the head of the patient. You can ask the patient to close his eyes so that it won't bother him. Gently inspect the inside of the nose, avoiding the sensitive part. Okay. All right. So in that test, I already check the nasal mucosa, the nasal cavity, and the nares, inside the nares, the patient. Now I'm going to palpate for the tenderness, sinus tenderness. Okay. You can begin here. Avoid pressing the eye. You know the sinuses are here. Do you feel any pressure? Okay. Any pressure here?
Yeah, I feel pressure, but it's not painful.
It's not painful. All right. Very good. So findings, both nares are noted symmetrical. No nasal obstruction seen. Nasal mucosa is in pinkish color and no signs and symptoms of any inflammation. No perforation is noted, and the sinuses are not tender. So those are the things also that you have to look for while doing the nasal examination and paranasal sinuses. So this time examination of throat, which covers the mouth and pharynx. Now, if your patient wears dentures, offer a paper towel and ask the patient to remove them so that you can inspect the underlying mucosa. If you detect any suspicious ulcers or nodules, put on a glove and palpate lesions, noting any thickening or infiltration of the tissues that might suggest malignancy. So this time I'm going to inspect the lips first. And I'm going to observe the color, moisture, and any lumps or ulcer or cracking or scaliness. So all I have to do is visually, you can open your mouth a little bit, not that wide. So he has a normal mouth and it's pinkish and a little bit dry. Okay, this time I'm going to check the oral mucosa by looking into the patient's mouth, and with a good light and help of a tongue blade, inspect the oral mucosa for color, ulcers, white patches, and nodules. So just gonna use this as my tongue depressor. I call it tongue depressor or tongue blade just to assist the tongue. But if your patient or if he will complain, then I have to remove it. But that's how it's gonna help you a lot is to use a tongue blade. Okay. So I'm gonna use also a pen light. Okay, this one. Instruct the patients to open the mouth. Okay. Since there's no inflammation, and can you put your tongue out a little bit? There's no inflammation. I don't see any white patches. Okay, the mouth is healthy. It's healthy, it's pinkish in color. Okay, this time I'm going to inspect the gums and teeth. Note the color of the gums, which are normally pink. Okay, brown patches may be present, especially but not exclusively in dark-skinned individuals. Inspect the gum margins and the interdental papillae for swelling or ulceration. Inspect the teeth. Are there any of them missing, discolored, misshapen, or abnormally positioned? To assess tooth, jaw, or facial pain, palpate the teeth for looseness and gums with your glove, thumbs, and finger. So the roof of the mouth and inspect the roof of the mouth, you inspect the color and architecture of the hard palate. So we're gonna use, of course, pen light. Wash your hands, which I did, and a pair of gloves. Okay, because this will help you assess thoroughly the gums and teeth and the palate. Okay. I'm just gonna open your mouth a little bit. Yeah. Okay, now inspect your. Okay. I'm gonna use I need to use the pen light. Sorry. You can pull the lips a little bit, but make sure the patient is not hurting. And if the patient complains of pain, then there's another problem. Okay. No missing teeth. Teeth is a little bit yellowish in color, which is normal. Open your mouth. I'm going to check the palate. Okay. Normal. I don't need to palpate it inside because I can see if there's no inflammation. If there is, I don't recommend touching it, especially if it is too painful, but may need further evaluation. Okay, this time we're going to test the tongue, assess the tongue and the floor of the mouth. So I'm gonna ask this patient to put his tongue out and I will check the symmetry. Okay, symmetry, there's a little bit white patches on the bed of the tongue and mouth. Thank you. So this time, inspect the entire oral cavity, especially the slides and undersurface of the tongue and the floor of the mouth areas where cancer often develops. Note any white or reddened areas, nodules, ulceration. Wearing gloves to palpate any lesions, ask the patient to protrude the tongue with your right hand, grasp the tip of the tongue with a square of gauze, and gently pull it to the patient's left. Okay, which I'm going to demonstrate now. And I'm going to wear gloves. Okay. Wear gloves, and I have a piece of cotton gauze here. We already checked the entire cavity a while ago. Can you put your tongue out? Okay, so I'm gonna press it on the side. Put your head on the side. Okay. Okay. This is how you will pull the tongue. You can do it. Pull it towards here and then on opposite, or you can do it this way. Put your tongue out. Press it. Okay. Okay. You can use a gauze to avoid the salivation dropping on the floor. So there is no white patches or lesion that I noted. Now we're going to check the pharynx. So with the patient's mouth open but the tongue not protruded, I have to ask the patient to say ah or yawn. This action helps you to see the posterior pharynx well. You can also ask the patient to open the back of the throat, since many adults have learned to inspect their own posterior pharynx while looking into the mirror. Alternatively, you can press tongue blade firmly down on the midpoint of the arched tongue, back far enough to visualize the pharynx, but not so far that you cause gagging. Simultaneously ask the patient's ah or yawn. Note the rise of the soft palate. But in this case, I'm just gonna ask the patient to say ah and yawn, and I will observe his pharynx. Can you say ah? Okay, can you yawn? Okay, all findings. Lips are pinkish in color with accurate amount of moisture. No lesions or cracks noted. Oral mucosa is color bright red with no signs and symptoms of any inflammation. Gums appear to be healthy, no swelling noted. Teeth are light yellowish and some are white in color. Tongue is generally pink in color with whitish coating on the surface. Absence of ulcers, lesions, and lumps. Oral cavity is healthy, no signs and symptoms of inflammation. The pharynx appears pink in color and is smooth and is consistent in texture. The uvula, which I just saw, is pink and rounded and no signs of inflammation. Okay, this time I'm going to do examination of the neck. We're going to begin the lymph nodes. So palpate the lymph nodes using the pads of my index and middle fingers. Press gently, moving the skin over the underlying tissues in each area. The patient should be relaxed with the neck flexed slightly forward, and if needed, turn slightly toward the side being examined. You can usually examine both sides at once, noting both the presence of lymph nodes as well as asymmetry. For the submental node, however, it is helpful to feel with one hand while bracing the top of the head with the other. Feel this and then feel the lymph nodes as it is. Okay, I'm going to demonstrate it now. Okay. Make sure you know the location of the lymph nodes. So for example, for this patient don't have any problems with the lymph nodes, okay? But let's pretend he has. So what you're gonna do is make sure to do it one at a time. So you can move the patient's head on the side and then examine it and watch for the asymmetry. Same as on the other side. I will do it in this way. So in this manner, I can see this the symmetry or asymmetry if there is asymmetry. But his neck is symmetrical. Okay, this time I'm going to fill the sequence of the following notes. The preauricular, which is in front of the ear, posterior auricular, which is the superficial mastoid process, occipital at the base of the skull posteriorly. So I'm going to use the pads of the second and third fingers, palpating the notes. Okay. I go. Here is the preauricular, the posterior auricular, and the occipital. Okay. In addition, check also the tonsillar, which is located at the angle of the mandible. Okay, I'm gonna demonstrate to how to palpate or feel the notes in submandibular and submental. In this clip, submandibular, submental. Submandibular is midway between the angle and the tip of the mandible. These nodes are usually smaller and smoother than the lobulated submandibular gland against which they lie. The submental in the midline, a few centimeters behind the tip of the mandible. So I'm going to demonstrate how to feel the nodes in the superficial cervical and posterior cervical. This is the superficial and the posterior cervical. Superficial cervical and posterior cervical. There is no pain. Superficial to the sternocleidomastoid and the posterior is along the anterior edge of the trapezius. So for the deep cervical chain, the deep to the sternocleidomastoid and often inaccessible to the examination, I will just demonstrate and how to hook my thumb and fingers around either side of the sternocleidomastoid muscle to find them. But I'm just going to demonstrate it. So hook the thumb, see, like this. In some, you can do this too. Use the forefinger. Additionally, the supraclavicular, which is deep in angle formed by the clavicle and the sternocleidomastoid. Feel and locate any deep cervical chain. Okay, this time I'm going to inspect the trachea for any deviation from its usual midline position. Then palpate for any deviation. So what I'm going to do is I'm going to place my finger along one side of the trachea and note the space between it and the sternocleidomastoid. Compare it with the other side. The spaces should be symmetric. Okay. There is a trachea. You have to be gentle. Now I know that it's symmetrical. Okay. There you are. It's symmetrical. Now, you can also use your stethoscope through auscultating breath sounds over the trachea. This allows subtle counting of the respiratory rate and establish a point of reference when assessing upper versus lower airway cause of shortness of breath. When assessing shortness of breath, always remember to listen over the trachea or stridor and upper airway etiologies in addition to examining the lungs, which we will demonstrate now. So all you have to do is listen for any stridor. No stridor noted. Okay, this time we're going to inspect the neck for the thyroid gland. Tip the patient's head slightly back using tangential lightning directed downward from the tip of the patient's chin. Inspect the regions below the cricoid cartilage to identify the contours of the gland. I'm gonna just demonstrate it. Okay, move your head on the side. Tangential lightning. You can see it here. Okay, this time we're going to observe the patient swallowing. So I'm gonna ask the patient to sip some water and to extend the neck again and swallow. So what I'm gonna do is I'm gonna watch for upward movement of the thyroid gland, noting its contour and symmetry. The thyroid cartilage, the cricoid cartilage, and the thyroid gland all rise with swallowing and then fall to their resting positions. And then I will confirm it visually, observing by palpating the gland outlines as I stand facing the patient. Go ahead and swallow. No, yeah, I can see the butterfly shape in his throat. Okay, as I mentioned earlier, to confirm my visual observation by palpating the glands outlines as I stand facing the patient, so this will help me to prepare for more systematic palpation to follow. And then I'm going to palpate the thyroid gland. This may seem difficult at first. Use the cues from the visual inspection. Find the landmarks, okay, the notch thyroid cartilage and the cricoid cartilage below it, and locate the thyroid isthmus usually overlying the second, third, and fourth tracheal rings. So I'm going to locate the landmark. So it's here. I'm going to palpate it. Okay. Now I'm going to behind the patients. I'm going to place my middle finger in the thyroid gland, and I'm going to ask him to sip water again. Okay, very good. So on the lateral side, I have to palpate it and look at it. All right. Now to check for any bruit, of course you have to use the stethoscope. Thank you. So lip nodes are symmetrical, absence of deviation noted. Trachea is in the midline position. The movement of the thyroid gland is normal, and patient did not display any discomfort during swallowing. Okay, so this time we're going to examine the respiratory, which we actually did demonstrated it in the previous units, unit 4, but I will re-demonstrate basic things. We'll count respiratory rate in 1 full minute, and I'm going to auscultate lung sounds, breath sounds after. Okay. All right, let me find where's the right. I want you to breathe normally. Okay, it's 20 breaths per minute. So I'm gonna do auscultate the breath sounds. Okay. Breathe in and breathe out. Breathe in and breathe out. Inhale. Breath sounds are louder in the upper anterior lung fields, and bronchovesicular breath sounds heard over the large airways on the right. So this time we're gonna do the cardiac assessment, which is we've done it in Unit 4, but I'm gonna go ahead and do the basic. So auscultation of heart sounds as a review. The diaphragm of the stethoscope is better for higher pitched sounds, murmurs of aortic and mitral regurgitation, pericardial friction rubs. The bell of the stethoscope is more sensitive to low pitched sounds, the S3 and S4, murmur, and mitral stenosis. If diffuse, PMI plus S3 suggestive congestive heart failure. Okay, then we have to look for elevated JVP. But okay, now I'm gonna listen to S1 and S2, right second interspace aortic area, left second interspace pulmonic area, and left third interspace, left fourth and fifth interspaces, tricuspid area, and apex mitral area. So basic auscultation of heart sound. Sorry for the dog. I'm not gonna hurt Daddy. Aortic RS2 is louder than S1. Pulmonic area S2 is louder than S1. And then she has no pain, no history of cardiovascular disease. Okay, so I'm going to re-demonstrate the gastrointestinal tract. So I'm going to auscultate and provides important information about bowel motility. So I'm going to auscultate the 4 quadrants for the gastrointestinal assessment. Okay. So I'm going to locate the patient's abdomen, the quadrants. Okay, it's here. I'm going to start here. And now this gurgling sound. So he has normal bowel sounds. I heard clicks and gurgles with an estimated frequency of 5 to 34 per minute. Right upper quadrant noted boborgigmi or stomach growling. Are you hungry? Okay, this time I'm going to assess by interviewing the patient about the genitourinary. So I'm going to ask the patient some questions. So, do you have any problems or concern in reference to genital area?
No.
Good. Do you have any problems and concerns in your urination?
No.
Okay. When was your last or recent prostate exam? If you remember.
I don't remember. It was a couple of years.
How about the colonoscopy?
That was a couple of years ago.
Okay. So patient has no issues in and concern in the genital area, and the prostate exam was done a couple of years ago, and colonoscopy was done, I believe, in November of 2018. So this one, I'm going to examine the mandible. I will inspect first and palpate, inspect the face for symmetry, inspect the temporomandibular joint or TMJ for swelling or redness, and to locate and palpate the joint, I'll place the tips of my index fingers just in front of the tragus of each ear and ask the patient to open his mouth. The fingertips should drop into the spaces as the mouth opens, and check for smooth range of motion. Note for any swelling or tenderness. Snapping or clicking may be felt or heard in normal people. So, it's here, and then open and close your mouth. Open. Okay, thank you. So no swelling or redness noted, and the face is symmetrical. So this time I'm going to palpate the muscles of mastication. Palpate the masseters externally at the angle of the mandible. Palpate the temporal muscles externally during clenching and relaxation of the jaw. And palpate the pterygoid muscle internally between the tonsillar pillars of the mandible. Clench the jaw. I can feel it. Yep. Very good. So no abnormalities noted, and range of motion. So the range of motion is threefold. Okay, I'm gonna ask the patient to demonstrate opening and closing, protrusion and retraction by jutting the mandible forward and lateral or side to side motion. Okay, cool. Thank you. Normal mouth noted, able to open widely, and during protrusion of the jaw, the bottom of the teeth able to place in front of the upper teeth. All right, this one is to examine the shoulders. First, I'm going to inspect the shoulder and the shoulder girdle anteriorly, then the scapulae and related muscles posteriorly. No swelling, deformity, muscle atrophy, or fasciculations or abnormal positioning noted. Okay, this time I'm going to look for swelling of the joint capsule anteriorly or a bulge in the subacromial bursa under the deltoid muscle. So I'm going to inspect, look for swelling of the joint and capsule anteriorly or any bulge. Okay. Deltoid muscle. Okay. The upper extremity has no skin color change and the skin is fair. Normal bony contours noted. Okay, now we're going to palpate the sternoclavicular joint, beginning medially at the sternoclavicular joint Trace the clavicle laterally with the finger. From behind, follow the bony spine of the scapula laterally and upward until it becomes the acromion. Okay, the summit of the shoulder. Its upper surface is rough and slightly convex. Identify anterior tip of the acromion. With the index finger on top of the acromion, just behind its tip, press medially with thumb to find the slightly elevated ridge that marks the distal end of the clavicle at the acromioclavicular joint. Move the thumb medially and down a support step to the next bony prominence, the coracoid process of the scapula. And then with the thumb on the coracoid process, allow the finger to fall on the grasp and lateral aspect of the humerus to palpate the greater tubercle where the sits muscles insert, which I'm going to demonstrate now. Okay. So it's here. And then can you move on this side so not shorter than the back side here. So. This is the scapula, the bony parts, and there you go. On the other side too. Okay, next is to palpate the biceps tendon in the intertubercular bicipital groove. Keeping the thumb on the coracoid process and the finger on the lateral aspect of the humerus. Remove the index finger and place it halfway between coracoid process and the greater tubercle on the anterior surface of the arm. Okay, so as I check the tenderness, rolling the tendon under the fingertips, it could be helpful. Now I can rotate the glenohumeral joint externally, locate the muscle distally near the elbows, and track the muscle and its tendon proximal into the intertubercular groove. All we have to do is find any tenderness, locate the greater trochanter and the bicep. For any tenderness, do you feel any tenderness? This is the landmark. Alright, this one is to examine the subacromial and subdeltoid bursa and the sits muscles. First, passively extend the humerus by lifting the elbow posteriorly, which rotates these structures so that they are anterior to the acromion, and palpate carefully over the subacromial and subdeltoid bursae. I'm going to demonstrate it now. Side here. Side. Okay. All right, I just want to show where the sits muscles are. Supraspinatus is directly under the acromion. Infraspinatus posterior to supraspinatus. Teres minor posterior and inferior to the supraspinatus. And subscapularis inserts interiorly and is not palpable. All are located at the upper, almost deltoid area. So when you flexed posteriorly the arm, you can see. Do you have any pain? Okay, so everything is here. So you have to look for any tenderness.